A very warm good morning. Welcome to another interesting session of Quest. May I invite our dear chaplain Thomas Achan to lead us in prayer.
Let's pray. പിതാവിനും പുത്രനും പരിശുദ്ധഹായിക്കും സ്തുതി. അതേപോലെ നീക്കം തന്നെ ആമേൻ. പരിശുദ്ധനായ ദൈവമേ, സ്വർഗസ്ഥ പിതാവേ, ഈ ഡിസംബർ മാസത്തിൻ്റെ രണ്ടാമത്തെ വ്യാഴാഴ്ചയ്ക്കായി നന്ദി. ഇന്നും ഞങ്ങൾ കേൾക്കുവാൻ പോകുന്ന കാര്യങ്ങൾ ഞങ്ങൾക്കതൊരു പ്രചോദനമായി തീരുവാൻ സഹായിക്കണമെന്ന് പ്രാർത്ഥിക്കുന്നു. ഇന്ന് അത് ലീഡ് ചെയ്യാൻ പോകുന്ന ബ്രദർ അരോമലിന് വേണ്ടി പ്രാർത്ഥിക്കുന്നു. ദൈവത്തിൻ്റെ സാന്നിധ്യം കൂടിയിരിക്കണമേ. ഞങ്ങൾ കേൾക്കുന്ന കാര്യങ്ങളൊക്കെ ഞങ്ങൾക്കും ഹോസ്പിറ്റലിനും മറ്റുള്ളവർക്കും അത് പ്രയോജനകരമായി തീരുവാൻ സഹായിക്കണമെന്ന് പ്രാർത്ഥിക്കുന്നു. ഒരു പ്രാവശ്യം കൂടെ ഈ വർഷം മുഴുവൻ ദൈവം ഞങ്ങളെ പുതിയ പുതിയ കാര്യങ്ങൾ കേൾപ്പിച്ച വലിയ ഈ സംരംഭത്തിനായി നന്ദി. ഇനിയുള്ള ഈ ആഴ്ചകളിലും ദൈവം ഞങ്ങളോട് കൂടെ ഇരുന്ന് പുതിയൊരു വർഷത്തിലേക്ക് കാൽവയ്പ്പാൻ ഞങ്ങളെ ഒരു ഹോസ്പിറ്റലായി ഒരു കുടുംബമായി ഞങ്ങളെ അനുഗ്രഹിച്ചാട്ടെ. പ്രാർത്ഥന കേട്ടതിനായി നന്ദി. ഞങ്ങളുടെ കർത്താവും ഞങ്ങളുടെ രക്ഷിതാവുമായ യേശു ക്രിസ്തുവിൻ്റെ വലിയൊരു നാമത്തിൽ തന്നെ ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Good morning, everyone. A warm welcome to all of you for today's quest. I'm Dr. Anne Mary John from the Department of PMR, and I would like to introduce the speaker of the day, Mr. Arumal Prasad, our young dynamic deglutologist from our department. Mr. Arumal has done his bachelor's degree in audiology and speech language pathology and master's degree in deglutology, both from Amrita Institute of Medical Sciences, Kochi. Apart from his expertise in diagnosing and managing swallowing disorders, he is skilled in advanced instrumental assessments like video fluoroscopic swallowing study, fiber optic endoscopic evaluation of swallowing, and flexible laryngoscopy. His area of interest include neuro and oncodysphagia, geriatric swallowing disorders, aspiration risk and airway safety management, tracheostomy and NGT care, rehabilitation in head and neck oncology patients, swallowing rehabilitation, and caregiver education. With a strong academic background and unwavering commitment to ensure safe and efficient swallowing, he has become an integral part of our rehab team. And today, he'll be talking about advancing deglutology, a year of clinical progress and evidence-based practice. Over to you, Arumal.
Hi, good morning, everyone. So, thank you for the brief intro, Anne ma'am. My name is Aromala, and I'm working as a deglutologist in the speech and swallow unit under the Department of PMR. And my topic of presentation for today will be advancing deglutology, a year of clinical progress and evidence-based practice. So, some of you may have not heard the name deglutology or deglutologist. So, it's basically the study of swallowing disorders. Deglutology is a study of swallowing disorders, and a deglutologist is someone who has an expertise in the assessment and management of these swallowing disorders. So we'll jump into the topic. So starting from the basics, why swallowing matters. So swallowing is a complex coordinated neuromuscular action which supports your nutrition, hydration, and overall well-being. And it actually happens about 600 to 900 times a day, even without us knowing. That is around once every minute, and even in our sleep it happens once in every 3 hours. So it happens around 600 to 900 times a day. Okay, so swallowing disorders or dysphagia, the term dysphagia is actually derived from two Greek words, where dys meaning bad and phagein meaning to eat. So it can be caused due to several reasons, including the neurological, structural, muscular, iatrogenic conditions. And dysphagia can be classified into mainly three. They are oral, pharyngeal, and esophageal dysphagia. So we all know what dysphagia is. What do we say? Dysphagia is the difficulty in eating. So actually we can give a proper definition for dysphagia. That is, as I quote Tanner et al. In 2007, that is, he said that it's the impairment of the emotional, cognitive, sensory, or motor acts involved with transferring a bolus from the mouth to stomach that results in failure to maintain hydration and nutrition and posing a risk of choking and aspiration. So dysphagia is not only difficulty in swallowing, it's not just a structural problem. So dysphagia can be considered as an impairment of the emotional, cognitive, sensory, or motor problems. Okay. So when we look into the prevalence of dysphagia in India, it's said to be highest in the elderly population, that is people above 60. So you can see a huge discrepancy, that is 36.6% and 66%. That's about 30% discrepancies there. That may be due to a large underreporting of dysphagia cases in India. So that is, there is no definite assessment and no proper diagnosis of dysphagia in India. So that's why there's a huge discrepancy between the prevalence percentages. So, and also in stroke survivors, it's said to be 47.7% of pool prevalence in India. And in Kerala, more than 77% of acute stroke patients had dysphagia, according to a recent study. So these are the common symptoms of dysphagia that include feeling of food stucking in your throat, coughing or choking while eating, then frequent drooling, pain or discomfort while swallowing, regurgitation. These are the common symptoms of dysphagia that we see. Okay. So sometimes we often forget the late signs of dysphagia. Okay. So these include fever spikes, reduced saturation levels, chest infections. So these are also caused by the aspirated content reaching the lungs and thereby causing an infection, that is aspiration pneumonia. Okay. So one main part of dysphagia is aspiration. Can someone explain what aspiration is? Give me a short definition of what aspiration is. Anyone? Okay, aspiration means something going into the lungs, right? Okay. So have anyone heard the name penetration? We all know what aspiration is. I'll explain penetration in simple terms. So you can see there's a diagram of a traffic light. Okay, the green part is the safe swallow, the red part is the aspiration. Green part means we are safe for everything, red part means we are not safe for anything. So penetration comes in between a safe swallow and an aspiration. Is it a problem? Yes. Is it that severe? No. So I've shown two diagrams. In the top right, you can see a image of the penetration. The red stuff is the content that can be food, liquid, or anything foreign. So it has not gone below the level of vocal cords. You can see the definition of penetration. It happens when anything other than air enters the laryngeal vestibule but does not go below the true vocal cords. Okay. Whereas in aspiration, it goes beyond the true vocal cords and into the trachea or the lungs. So which one would be more severe for us? Definitely aspiration. Yeah. So is penetration considered a high risk? Yes, in only some cases. That is, when it is deep reaching the level of vocal cords, when it is silently going into the laryngeal inlet, when it is recurrently observed with different consistencies and quantities, and also when it is associated with delayed swallow initiation or poor airway protection. Okay. So what are the complications of dysphagia? It's not only a structural or functional problem, it can be a psychological, emotional, as well as a social problem. So dysphagia can also cause malnutrition, dehydration, aspiration pneumonia, increased hospital stay, etc. All right. So we'll jump into the next part, that is the assessment of dysphagia. So basically the assessment of dysphagia starts with taking a proper case history, including the dysphagia history, then a general observation of the patient, that is the patient's mobility status, respiratory status, and cognitive status and all. We'll go on to the oral peripheral mechanism examination, that is the structural and functional properties of their tongue, cheeks, jaws, and every articulators. Then we'll go with the cranial examination, mainly the 5th, 7th, 9th, 10th, 11th, and 12th cranial nerves. Then we'll be doing the bedside water swallow test. So mainly the clinical bedside evaluation goes to the bedside swallow test. That is these are some of the common signs we see during an oral trial. That is, we give the patient food or liquid to eat or drink, and we check for the clinical signs and symptoms. So these are the common signs and symptoms we see during an oral trial, that are coughing or choking, drooling, delaying swallow initiation, then voice change and shortness of breath. All right. So this is actually surprising that more than 70% of the time we overdiagnose dysphagia at bedside using clinical signs and symptoms only. Okay, so for some patients, even though there is no dysphagia, we overdiagnose it as the patient is having a dysphagia because we saw a cough. I gave water, patient coughed, patient is having dysphagia. Okay, so due to the limitations of the bedside examinations and need for objective visualizations and benefit for diagnosis and treatment planning, we often go into an instrumental swallowing assessment. So mainly we have two instrumental swallowing assessments for dysphagia. And the first one being FEAS, that is flexible endoscopic evaluation of swallowing. It's an endoscopic procedure including a small thin nasal endoscope. We pass it through the nose and we visualize the upper airway, that is the larynx and all. So it shows laryngeal function, residue, secretions, aspiration, everything. We can do it at bedside itself, and it also allows real food testing. Okay, so these are the indications for FEAS. That is, some of them are when we suspect silent aspiration, when we need to assess the laryngeal function, airway protection, we need to see the vocal cord status, then postoperative or structural conditions, then suspected behavioral swallow disorders. So these are some of the indications for doing a FEAS. I'll show you guys a short video of how we do a FEAS.
Hi, Addie. I'm Carrie. I'm a speech pathologist. I'm going to be helping out with the evaluation today. We're going to be doing a type of swallowing evaluation where we put a camera in your nose and we give you different consistencies of food items to swallow and watch you swallow those. This is the camera we're going to use. It goes in your nose about this far, just a little bit past that white line. There's not much space between your nose and your throat, so it doesn't have to go in very far. We're not in there very long, just long enough to take a look around at the anatomy, give you a couple of things to eat and drink, and watch you swallow those, and then we come out. Okay? So the different items we're going to be swallowing, we like to do an assortment of consistencies. So we do a thin liquid, a puree, and then a solid consistency. I put a little green food coloring in the liquid and the puree. That just allows us to see it better when the camera's in place. Okay?
Ready?
That's it.
Absolutely works perfect there.
Right now we are seeing
Can you
the
see?
throat, and we'll ask the patient to phonate. That's actually we are trying to check the vocal cord status, if it's functioning or not. You can see the airway going down
Ready
the
for
middle,
me?
and food should be going around it.
Go ahead and take a couple more for me. Good.
Actually, we can try different consistencies and different quantities of food or liquid during a piece, and we'll only add some color so that we can visualize it well. We actually give a green color here. Some people use blue, some people use white. It depends.
The other hand. There you go. Go ahead and take a bite of one of those.
You can see a little bit of residue there in the throat. That is the green colors there. Right now she's chewing the biscuit and everything. Right, so that's how we do a
And
feast.
one
Okay. So the down part of
You can
feast is that we are not able to visualize the
That's it.
oral cavity, that's the
I'm done.
mouth, and whatever happens below the larynx.
You did it.
So we are not able to visualize the oral face and the esophageal face in face. Only we can see only the pharyngeal face. That is what happens in the throat. If there is, we can identify if there is a aspiration, penetration, if there is any residue, if there is any structural abnormalities or muscle dysfunction or anything. We can actually make it out from the face. Okay. So next is the VFSS, or the video fluoroscopic swallowing study. So it's a dynamic X-ray evaluation of the swallowing mechanism using barium-coated food and liquid to visualize all the phases of swallowing. So this is the only test that visualizes the entire swallowing function from mouth to esophagus in a single continuous view. So it also follows strict radiation safety protocols. So this VFSS is actually called the gold standard of swallowing evaluation because this is the only test that where we can see the all the phases of swallowing. All right. In fees, as I told earlier, we are not able to visualize the oral and esophageal phases. Okay. So these are the indications for fees. Suspect aspiration during feeding, coughing or choking with swallowing, then recurrent chest infections, neurological disorders affecting swallowing, structural or anatomical abnormalities, pediatric feeding difficulties, etc. So I'll show you guys another video of the VFSS. On the left hand side, you can see a normal swallow. That's the way the food should go, and that's the way the air should go. So that's the normal swallowing. We have coated the food with a barium. That's why it's showing us a black color, the contrast. You can see the liquid has already aspirated into the larynx. And one more thing is the patient is not showing any distress, no cough, no throat clearing, no nothing. So this is a case of silent aspiration. So if we had done something clinically and we had given anything orally, like clinically, and the patient was not coughing, that doesn't mean the patient is not aspirating. Okay. So this is why instrumental evaluations are so important for treating and evaluating dysphagia. Okay. So this is the simultaneous view of a VFSS and a FEES. On the left hand side, you can see a X-ray image. The black color is the contrast, and on the same thing, you can see the on the right hand side, you can see the FEES image. That's the barium that's on the white color. So that's mainly about the assessment of dysphagia. Next, we'll go into the management of dysphagia. So is it just exercises? Is it just rehabilitation exercises? No. Actually, management of dysphagia is multifaceted. Okay. We have the rehabilitatory exercises, including the effortful swallow, Masako, shakers, showas, CTR. There are different types of rehab exercises targeting different muscle groups and different conditions. We also have compensatory strategies. They include head turning to the left side or the right side. They mostly include the body positioning to facilitate the food through the better side. Then we also have the modified diet. Okay. So this may be a new thing. Actually, it's called an IDDSI framework, the International Dysphagia Diet Standardization Initiative. So they have classified the food and drinks into 7 types. That is starting from thin liquids, that is level 0, and going all the way up to level 7, that is the regular food. So in some patients, like especially the stroke patients, they might be having dysphagia for only thin liquids. They'll not be able to drink thin liquids. They can aspirate. So in such cases, there is actually no need of putting an NGT. Rather, we can just thicken the liquids. That is, we can use a slightly thick or a mildly thick liquid and make the patient's swallowing safer. So in our, this is an example of dysphagia diet. That is, on level 3 we have broth, level 4 is yogurt, level 5 is mashed potatoes. With the increasing number of levels, the thickness also increases. All right. So this is actually an example of modified diet, which we can see outside. They have, as you can see, they have all the varieties like home style beef, French toast, everything mashed up into a pureed consistency, which is what we lack in India actually, because what we make in north is not the same in the south. What we make in the east is not same in the west. Okay, so in outside they have certain modified diets for certain consistencies, certain tastes, certain foods. So they also have this specialized mold where they can mash the food and later turn it into the same shape so that the patient gets a visual appeal for the same. All right. So thicken liquids. So this is a product of the Nestle. It's called Thicken Up Clear, and it's actually used to thicken the liquids, increase the consistency of thin liquids. So as I told earlier, some patients will be aspirating for thin liquids. So instead of putting a NG tube, we can actually thicken the liquids and give it to the patient. So the indications for using a thickener is coughing or choking with thin liquids, then weak cough reflex, poor tongue control, reduced laryngeal elevation, then delayed swallow reflex, etc. So we'll see how we make a thickened liquid. You see that they are preparing these slightly thick liquids, that is 1 scoop for every 200 ml. Okay. Actually, they'll be increasing number of scoops per 100 ml, and they can make mildly thick, moderately thick, extremely thick, and different consistencies of thin liquids. Sorry for the delay. So that's all about thickened liquids. And the next one is medical management of dysphagia. That is mainly from the medicine side. That is we can use proton pump inhibitors for GERD, steroids for inflammatory causes, then treat the underlying neurological conditions, then antibiotics or antifungals if there is an infection that's causing dysphagia. The next one is the surgical or interventional management of dysphagia. Those include dilatation of strictures, Botox injection for achalasia or CP spasm, then Nissen's fundoplication for reflex, myotomy, etc. So next I want to talk about the alternate modes of feeding. Quite big topic. So on the left hand side you can see all the alternate modes of feeding that starts from the modified oral feeding which I showed earlier. Then we have the NGT, orogastric tube, peg or rig feeding, PEJ feeding, GJ tube, then total parenteral nutrition. So we can use all of this for different indications based on the patient's condition, comorbidities, age, and other factors. Okay. Next are the feeding tubes. It's also called nasogastric tubes or NGTs. So this is the common Riles tube we use in our hospital, in almost every hospital. So it comes in different Frenches. That is, the most common used ones are 14 French and 16 French. So the pricing comes around 6 to 14 per piece. That's quite surprising actually. comes below 30 rupees. One Riles tube comes below 30 rupees. And the Riles is actually a brand. The main term is a nasogastric tube, and Riles is just a brand for the NGT. And it's actually not made for long-term feeding. Okay, it's actually made for short-term feeding and other uses like gastric aspiration, gastric insufflation, etc. The better one is a Freca tube. Okay, so its casing also suggests it's a tube made for feeding. Then the down part is its cost comes quite high, that is 750 to 950. But this tube can last for more than 3 months. It's actually made of a polyurethane material so that it doesn't react with the body temperature and everything. And also the size is actually 15 French. So in Riles tube, I've told that we use 14 and 16 Frenches usually. And the Freca tube size is actually what we use here is Freca tube size 15. Okay, that's so there will be no problem for the feed to go and all. So next is aspiration. Should we be really worried all the time? Okay. So how many of you think that aspiration causes aspiration pneumonia all the time? Does aspiration always cause aspiration pneumonia? What I want to say is no. Aspiration does not necessarily cause aspiration pneumonia. Okay. So I want to share a story. This is about a man who never got pneumonia. So this is actually a blog taken from the US. Mr. George Barnes is an SLP. He is actually working in a hospital. So he actually saw a patient with an acute stroke. And after the swallowing evaluation, they found out that the patient was silently aspirating on thin liquids. Okay. So what Mr. George Barnes or the SLP suggested is that we can either go for a NG tube insertion or we can try a thickened liquids. But the patient was a smart guy. He said that, no, I don't want to drink anything like a sludge. I don't want to put an NG tube. He said that I'll rather die before I eat or drink that sludge. So going with the patient, Mr. George Barnes or the SLP documented everything. He made the patient know everything about the risk of aspiration pneumonia and everything. And they let the patient eat everything orally. Okay. And the patient got discharged. So 2 months later, the same patient came back to the hospital. And Mr. George Barnes got to know that the same patient got readmitted. So what went through Mr. George Barnes' mind is that he should have counseled the patient a bit more. He should have presented the risks a bit more seriously, or else he shouldn't have got readmitted. So before reading the file, the SLP went to the patient's room and asked if the patient was willing for another swallowing evaluation. So what happened is the patient replied that, okay, after stroke, I understand that you guys, it's good to do a swallowing evaluation after getting a stroke. So he asked that, do you guys do it after a hip surgery also? So the thing is, he was not actually admitted for aspiration pneumonia. Rather, he fell at home and he broke his hip. He came for a hip replacement surgery. So it should be surprising, but it should be not. Actually, a patient probably would have aspirated for 2 whole months, but when they looked into his chest X-ray, it was clear as a crystal. So aspiration does not essentially lead to aspiration pneumonia all the time. So that is, the more we understand aspiration, the less we need to be afraid about it. So I told there are certain factors for an aspiration pneumonia. Okay. So in studies, it states that mainly 2 or more of these conditions should coexist for the patient to go into aspiration pneumonia. That is, the aspiration of contents should be harmful. Patient should be having a reduced pulmonary clearance, or the poor respiratory status. Then also an impaired immune response. So even if the patient aspirates something, if it's a healthy person, we do have our respiratory system. Okay. The respiratory system will expel it off. That's why we cough after aspirating. Okay, so aspiration is actually universal. It happens for everyone. It happens for me. It happens for ma'am. It happens for everyone. So the problem is, the main thing is, our respiratory system is good. We can fight it off. Our immune system is good. And even if something aspirates, our body will clear it off. Okay, so some of the two or more of these complications should coexist for a patient to go into an aspiration pneumonia. Okay. So every time you hear aspiration, you needn't be worried that he'll go into an aspiration pneumonia. As long as it is properly diagnosed, as long as it is properly managed, you shouldn't be worried. Okay. So medicine doesn't end with diagnosis. It ends with the delivery of appropriate care. So how do we build a service that does all this under one roof? To solve this, to streamline care, we implemented a dedicated clinic for the evaluation and management of swallowing disorders, focused on early identification and triage, comprehensive evaluation, consistent care pathways, and prevention of complications. So this is what went through our mind a year back, which led to the inauguration of our solo clinic a year back. So it was the same day. So it was on the 12th of December to be exact. 1 year back, we started the Believer Swallowing Clinic. So it was inaugurated on December 12th, and it was a multidisciplinary center exclusively for the treatment and assessment and management of swallowing disorders. So our mission was to deliver exceptional patient-centered swallowing care that enhances safety, function, and quality of life. So we followed a patient-centered approach. We put patient before anything else, and we also followed a multidisciplinary and holistic approach towards the management. Our focus was on nutrition, airway, and communication. And we also had several achievements after starting the swallowing clinic. We'll start from the basic one, that is the fees integration. Actually, the fees was initially established and successfully performed by our ENT team. And building on this existing expertise, we expanded the service through collaboration, addition of an advanced fees equipment, and development of standardized assessment protocols. So this was our fees equipment, and on the lower part, we can see our first patient whom we did fees for. It was actually an RTA case, and he was on a tracheostomy tube, NG tube, and everything. We changed the NG tube to a PEG tube, and after multiple swallowing evaluations, we were actually able to start everything orally for him. Right now, we even removed the PEG tube and everything. He's eating everything orally. He's speaking very well. So, and next one is the impact on patient care. We were able to discharge patients very easily and quite early due to proper management and assessment. And we had increased accessibility for swallowing assessment, improved diagnostic accuracy and treatment planning, then standardized and evidence-based protocols, enhanced training opportunities for clinicians. Next one is the faster NGT and tracheostomy decannulation. Okay, after we implemented fees, we were able to actually do the NGT and tracheostomy decannulation quite faster than before. Okay, then we saw reduced complications and length of stay, early detection of silent aspiration, more referral across disciplines, better diet decisions, and also we standardized the swallowing evaluation protocols after starting the swallowing clinic. We were able to document very well. Then we had evidence-based checklists and revised evaluation forms. Then we also conducted a state-level neurodysphagia symposium on the 24th of May. We had expert-led lectures and workshops featuring neurologists, SLPs, ENT, dietitian, and rehabilitation specialist, and live demonstration of instrumental assessment tools such as FEES and other neurophysiological markers in dysphagia. We had conducted an aspiration prevention protocol training for nurses, which was done in different sessions. We conducted a training for staff nurse because the staff nurses are the pillars, and they are the connection between the patient and the primary caregiver. So they are actually the front line, the first line of defense for us. So educating them is actually educating the patient. So we also had a growth in patient caseload and quality care. We saw a rise in dysphagia case referral, higher patient satisfaction, better clinical outcomes, and everything. So going to the 1 year summary, we were able to achieve this much. That is, fees was established, protocols were standardized, faster NGT and tracheostomy decannulation. We conducted a symposium, then nursing training was completed. We also had increased patient load. So our future goals are to introduce VFSS, which is actually would be a very good thing if we could start it. Then We are planning to expand our OP rehab and research and publications, community awareness, and universal solo screening. So the take-home message would be together we make our swallowing safer. So this is our team. So we have the same color in all of you in PMR. So if you see any three of these guys, you can actually refer any swallowing cases if you have any. And thank you for your participation. We are open for questions.
Thank you, Aromal, for that wonderful presentation. I'm really happy to hear all these things, like especially he has given a wonderful explanation of all these things, especially about fees and VFSS. So I think I don't know whether all the hospitals around us can boast about deglutologists, or even some hospitals do not have a speech and language pathology experts, but we have a deglutologist. So I think our department per se is an asset to believers. So I'm really happy to hear your talk on this topic. So before we go into the questions, I just want to ask one thing, because in our patients also, once they come to PMR, most of the time they'll tell us, okay, he has an NGT, we'll change it to FRECA. So can you just explain shortly what is the advantage? You said it's more costlier, but why do you prefer FRECA to NGT?
Right. So as an SLP, as a deglutologist, I never promote RILES 2. Okay. I always promote FRECA 2 because we prioritize on feeding. It is also, we have to maintain the nutrition and hydration of the patient in a safer way. So as I told earlier, our RILES tube is actually a PVC, or a polyvinyl chloride material. Over time, it will react with your body and it will get hardened. So അത് പോകുന്ന വഴിയെല്ലാം it can irritate your mucosa, the patient's mucosa. Okay, so first one is that the patient irritation ആയിരിക്കും. It's not very comfortable for the patient. It's also not meant for long term tube feeding. 10 to 14 days ആണ് നമ്മൾ റൈസ് ട്യൂബിൻ്റെ ഒരു കാലാവധി പറയുന്നത്. After that you need to change it. So if a patient was on NG tube feeding for 3 months, എത്ര തവണ പേഷ്യൻ്റ് ചേഞ്ച് ചെയ്തിട്ടുണ്ടായിരിക്കും? Okay, so and FRECA ട്യൂബിലേക്ക് വരുവാണെങ്കിൽ we can actually use a FRECA tube for more than 3 months. It's made of, ഞാൻ നേരത്തെ പറഞ്ഞ പോലെ, it's made of polyurethane material that does not essentially react with your mucosa. Okay, അതിൻ്റെ ഷെൽഫ് ലൈഫ് 3 months ആണ്. It's softer, flexible, very comfortable for the patient. So actually ideally NG tube feeding തന്നെ നമ്മൾ പറയുന്നത് 4 weeksന് മേളിലേക്ക് യൂസ് ചെയ്യരുതെന്നാണ്. So if we see that the patient has to go with an alternate mode of feeding for more than 4 weeks, we usually refer for a PEG or a RIG.
Okay, thank you, Aramal. Now we can take up questions. If any, please, Aramal is here to answer your questions.
Romal, that is a very good presentation. I just want your input in pediatric age group. Now, we find a lot of children with autism having failure to thrive. And yesterday also, I think I sent you a patient. So this is something which has to be addressed at the parental level. So what is your experience? How can you help us with these children in CDC?
So pediatric swallowing disorders and adult swallowing disorders are on two levels. Okay, so pediatric is also a little bit tricky, because even if in adult cases we can actually, if there is a problem, we can actually refer them for doing the rehab exercises, compensatory strategies, diet modification and everything. But for babies, we are not able to do all that. So we have to assess this. Diagnose it's a very important thing. So I guess with VFS, right now നമ്മളിപ്പോൾ ഫീസ് പീഡിയാട്രിക്സിൽ ആർക്കും ഫീസ് ഇതുവരെ ചെയ്തിട്ടില്ല currently. So we are planning to talk with the pediatrics team regarding the fees. And also I guess VFSS കുറച്ചുകൂടെ വന്നു കഴിഞ്ഞാൽ we'll be able to manage the feeding and swallowing disorders for pediatrics a bit more. Rather than that, clinically we can actually see the patient. We can provide certain therapy techniques and caregiver education and everything. Actually, so but I think instrumental evaluation is a big factor for that also.
Any other questions?
Romel, a nice presentation, well presented, and I'm very happy because I am a physiology professor, so deglutation I know all these things, but extra knowledge I got it from you so much, and it is presented in a beautiful way, and so we enjoyed it. And actually, I am a patient actually with GERD, hiatus hernia. Once I was admitted here, then speech ഓരോ ഡ്രോപ്പും കുടിക്കണമെന്നൊക്കെ പറഞ്ഞു. പക്ഷെ അങ്ങനെയൊന്നും അല്ലെങ്കിലും ഐ നോ ദാറ്റ് ബിക്കോസ് ഇങ്ങനെ പോകുന്നത്. സോ സംടൈംസ് ടോക്കിംഗ്, സോ വി ഹാവ് ടു ബി കെയർഫുൾ. ആൻഡ് ഓൾസോ അനദർ തിങ്, while talking actually food taking is very bad. Another thing is aspiration you said. It is very, I witnessed one of my ഒരു ക്ലെഫ്റ്റ് പൈലറ്റ് ഉള്ളതായിരുന്നു. LC ഫിലിപ്പ് മാഡത്തിൻ്റെ മോൻ ഞങ്ങളുടെ കോളേജിലായിരുന്നു ഡെൻറ്റൽ. സോ ഹീസ് എല്ലാവരെയും ഹെൽപ്പ് ചെയ്യുന്നത്. അപ്പോൾ ഒരു ആളുടെ കുഞ്ഞിനെ ഞങ്ങൾ കോട്ടയം മെഡിക്കൽ കോളേജിൽ കൊണ്ടുവന്ന് ചെയ്തു. അപ്പോൾ എൻ്റെ കസിൻ വിളിച്ചു പറഞ്ഞു, ഞാൻ വെല്ലൂരിൽ നിന്ന് വരികയായിരുന്നു ഒരു കോൺഫറൻസ് ഒക്കെ കഴിഞ്ഞ്. അന്നേരം ഓടി വന്നു. പക്ഷേ അപ്പോൾ ഓപ്പറേഷൻ കഴിഞ്ഞു, ഇറ്റ് വാസ് സക്സസ്ഫുൾ. എല്ലാവരും ആൻഡ് ദാറ്റ് ഹസ്ബൻഡ് ആൻഡ് വൈഫ്. അത് കഴിഞ്ഞ് രാവിലെ ഉച്ച കഴിഞ്ഞ് ഞാൻ പോകണമെന്ന് വെച്ചാൽ രാവിലെ ഉടനെ ഫോൺ കോൾ വന്നു. അപ്പോൾ എന്ത് പറ്റിയെന്ന് വെച്ചാൽ ഈ സിസ്റ്റേഴ്സ് അത്രയും ശ്രദ്ധിച്ചില്ല. ഈ കുഞ്ഞ് അവർ ബ്രസ്റ്റ് ഫീഡിങ് സർജറി കഴിഞ്ഞതാണ്, എന്തോ ചെയ്തു ആൻഡ് ഡെഡ്. അപ്പോൾ അവർ രണ്ടുപേരും കെട്ടിപ്പിടിച്ച് ഞങ്ങൾ രാജകുമാരി പോലെ വളർത്തിയ. എപ്പോഴും ഐ റിമെമ്പർ ദാറ്റ് ചൈൽഡ്സ്. അങ്ങനെ സോ മച്ച് ഓഫ് കെയർലെസ്നെസ് ഇൻ അവർ പാർട്സ് ഓൾസോ ക്യാൻ കോസ്. അപ്പോൾ ആഫ്റ്റർ പ്രത്യേകിച്ച് പോസ്റ്റ് സർജറി കഴിഞ്ഞിട്ടുള്ളത് വി ഷുഡ് ബി വെരി കെയർഫുൾ. അങ്ങനെയുള്ള കാര്യങ്ങൾ കണ്ടിട്ടുണ്ട് കുറേ, 1, 2, 3.
Okay. One more thing quickly before closing. We face a lot of aspiration pneumonia. Whenever an NG tube is there, when any patient, stroke, TBI, anything, when they come to us, when patient comes with an NG tube, aspiration risk is there. We are always scared about aspiration risk. So my question is, in our department, do we do fees for all patients? Like or aspiration chance all the patient, do we do it for all patients or how do you do?
ആക്ച്വലി ഞാൻ നേരത്തെ ഇൻഡിക്കേഷൻസ് ഫോർ ഫീസ് കുറച്ച് മുമ്പ് കാണിച്ചിരുന്നു. സോ അതിൽ തന്നെ ആക്ച്വലി നമ്മളിവിടെ ചെയ്യുന്ന പ്രോട്ടോക്കോൾ എങ്ങനെയാണെന്ന് വെച്ചാൽ, നമുക്ക് ക്ലിനിക്കൽ ഇവാലുവേഷനിൽ ഇഫ് ദർ ഈസ് എനിത്തിങ് ദാറ്റ് വി സസ്പെക്ട് ദ പേഷ്യൻ്റ് ഈസ് ആസ്പിറേറ്റിംഗ്, ദാറ്റ് ഈസ് വിൽ പേഷ്യൻറ്റിൻ്റെ നമ്മൾ ഇപ്പോൾ സ്ട്രോക്ക് ആണെങ്കിൽ ഫോർ എക്സാമ്പിൾ എടുക്കുകയാണെങ്കിൽ നമ്മൾ പേഷ്യൻ്റെ സൈസ്, സൈറ്റ് ഓഫ് ലീഷൻ, പിന്നെ സിവിയറിറ്റി ഓഫ് ലീഷൻ, അതെല്ലാം കോമോബിലിറ്റീസ്, ബാക്കി കണ്ടീഷൻസ് എല്ലാം എടുത്തിട്ടായിരിക്കും നമ്മൾ ബെഡ് സൈഡ് ഇവാലുവേഷൻ ചെയ്യാൻ പോകുന്നത്. ബെഡ് സൈഡ് ഇവാലുവേഷനിലും എനിത്തിങ് ഫിഷി ആയിട്ട് കണ്ടാലാണ് നമ്മൾ യൂഷ്വലി ഫീസിലേക്ക് പോകുന്നത്. ഓൾവേസ് ബെറ്റർ ടു ഡു ആൻ ഇൻസ്ട്രുമെൻ്റൽ ഇവാലുവേഷൻ ബിഫോർ സ്റ്റാർട്ടിങ് ഓറൽ ഫീഡ്സ്, ബട്ട് വി ഓൾസോ ലുക്ക് ഇൻ ടു ദി ഫൈനാൻഷ്യൽ പാർട്ട്. സോ പേഷ്യൻസിൻ്റെ ഒരുപാട് പൈസ കളയാണ്ട് എങ്ങനെയാണ് പേഷ്യൻറ്റ് റീഹാബിലിറ്റേറ്റ് ചെയ്ത് വീട്ടിലയക്കാം എന്നുള്ളതാണ് മെയിൻലി നോക്കുന്നത്. സോ ഈ ക്ലിനിക്കൽ ബെഡ് സൈഡ് ഇവാലുവേഷനിൽ എന്തെങ്കിലും പ്രശ്നം തോന്നിയാൽ മാത്രമാണ് മെയിൻലി നമ്മൾ ഫീസിലേക്ക് പോവുക.
Okay, thank you, Aromal. If there are no more questions, we can close. Okay.
No questions as such. I want to congratulate Aromal. I am from ENT. Before the Deglutology department started, we were always called for aspiration pneumonias and evaluation of larynx. When the team came in, we were much supported, and gradually I am happy that now we have a standardized protocol, and we always work together. When I have a problem, I call him. When he has a problem, they call us. So congratulations, Aromal, for all the good work.
Thank you so much.
So thank you everyone for coming. So have a nice day.